Bismillahirrahmanirrahim. The role of three-dimensional transrectal ultrasonography and power Doppler sonography in prostatic lesions evaluation. The key point for management of prostate cancer is our ability to differentiate between cancer localized to the prostate gland and cancer with extracapsular extension. Radical prostatectomy can be performed for patients with localized cancer to the prostate gland, but if the tumor extends beyond the prostatic capsule, other treatment options like radiotherapy, chemotherapy, hormonal therapy will be tried. The survival after radical prostatectomy performed for patients with localized cancer is comparable to that of men without cancers. Extracapsular extension of prostate cancer may lead to failure of radical prostatectomy, and it is very disappointing to inform the patient who had performed radical prostatectomy that he has a recurrent cancer or the cancer will recur in spite he was subjected to all operative and post-operative risks including urinary incontinence and impotence. Predictors of extracapsular spread of tumor are elevated serum PSA more than 10 nanogram per milli, Gleason score 7 or more, the presence of more than 20% of malignancy in biopsy tissue samples, the presence of perineural invasion in biopsy tissue samples. However, all these predictors do not offer more than 78% sensitivity in the prediction of prostate cancer. So, every attempt should be done to assess the site and the extensions of prostate cancer before surgery or before management, using more sensitive predictors like the imaging modalities in our hands. The aim of our current study is to evaluate the value of three-dimensional, two-dimensional, as well as power Doppler transrectal ultrasound in the diagnosis of different prostatic lesions and in the assessment of local extensions of prostate cancer. Methodology: two-dimensional transrectal ultrasound, power Doppler sonography, and 3D ultrasonography were performed for 100 patients. All patients were complaining of lower urinary tract obstructive and/or irritative symptoms. Among them, 77 patients were subjected to transrectal guided biopsy. The criteria to do biopsy were serum prostatic specific antigen for more than 4 nanogram per milli, percent free PSA less than 10%, abnormal digital rectal exam, the presence of abnormal focal lesion by transrectal ultrasound, the presence of area of abnormal vascularity with power Doppler sonography. 8 tissue samples were taken from different prostatic regions. 6 tissue samples were taken from the mid-lobe parasagittal planes bilaterally at the base, middle, and apical prostatic zones, and 2 samples were from the lateral aspect of each lobe. In addition, targeted tissue samples were taken from the suspicious focal lesions or from the seminal vesicles if there were suspected tumor infiltration observed during transrectal ultrasound. Trus and trus-guided biopsies were performed in an outpatient clinic. In cancer patients, the final diagnosis was reached based on the result of through-cut prostatic biopsies, target biopsies of the region of interest, post-radical prostatectomy pathological report, cystoscopy and biopsy of urinary bladder if suspected urinary bladder infiltration, and targeted seminal vesicle biopsy in cases with suspected infiltration. In patients with BBH, we estimate the volume of adenoma using two-dimensional and three-dimensional ultrasonography, and the results were correlated with the post-open prostatectomy or transurethral resection prostatectomy results. The results: 2D transrectal ultrasound aided with power Doppler and 3 Doppler transrectal ultrasound were performed for 100 patients. The final diagnosis was reached in 77 patients. 18 patients showed prostatic carcinoma, 1 patient showed prostatic sarcoma, 38 patients showed benign prostatic hyperplasia, 20 patients diagnosed as prostatitis. In patients with biopsy-proved prostatic cancer, 3D TRAS showed an estimated sensitivity 78.9% and specificity 94.8% with total accuracy 90.9% with respect to an estimated sensitivity 63%, specificity 86% and the total accuracy 80% with two-dimensional ultrasonography. 3D TRAS clearly identifies the extraprostatic spread to the periprostatic fat at 3 out of 3 patients, infiltration to the seminal vesicles in 3 out of 3 patients, infiltration to the base of urinary bladder in 2 out of 2 patients, and also the presence of capsular breaks in 4 patients out of 5. While two-dimensional ultrasonography was able to detect 2 out of 2 patients with bladder wall infiltration, 3 out of 3 patients with periprostatic fat plane infiltration, 2 out of 3 patients with seminal vesicle infiltration, and 2 out of 5 patients with capsular breaks. In cases with BBH, 3-dimensional transrectal ultrasonography was superior to the 2-dimensional ultrasonography in calculating the volume of adenomas, with an estimated error not more than plus or minus 6% with regard to an estimated error not more than plus or minus 18% for two-dimensional ultrasonography. In patients with prostatitis, the most valuable signs observed with power Doppler ultrasonography and 3-dimensional ultrasonography are accentuated periurethral halo ovulocency, periurethral hyperemia, and congested periprostatic venous plexus. Cases presentation. Normal 3D image of prostate. Frontal scan of seminal vesicles and vas differences. Stage 2B prostate cancer with 3D ultrasound image reconstruction. The tumor seen involving more than one half of one side of prostate gland. Here is an image of 3D reconstruction of pathological circulation in malignant prostatic mass. Here is a 3D reconstruction of prostate cancer with capsular breaks. Both 3-dimensional image and 2-dimensional image are seen together. Here is a 3D reconstruction of prostate cancer with areas of capsular breaks. Stage 3A prostate cancer showing periprostatic fat plane infiltration. 3-dimensional reconstruction. A coronal scan of prostate cancer with periprostatic fat plane infiltration. Multiplanar image analysis of a prostate cancer with periprostatic fat plane infiltration. A frontal scan of prostate cancer which seen extending behind the prostate capsule. A 3D reconstruction of a cancer involving the base of prostate gland with extraprostatic fat plane infiltration. A 3D reconstruction of a case of BBH associated with peripheral zone carcinoma showing extraprostatic fat plane infiltration. In this image, we see both BBH finding with intravesical protrusion of middle loop and the presence of malignancy involving the peripheral zone and infiltrating the prostate capsule extending the periprostatic fat planes. Here is a case of prostate cancer infiltrating the base of urinary bladder with 3D reconstruction. Vice versa, a case of urinary bladder cancer seen infiltrating the prostate with three-dimensional reconstruction image. Here is a case of BBH, and we can see that we are estimating the volume of adenoma using the three-dimensional transrectal ultrasound using the two-plane contour method. Here is a case of BBH, and we are estimating the volume of adenoma using the three-distance method with two-dimensional transrectal ultrasound. Here is a 3D reconstruction and power Doppler sonography of a case of prostatitis. Here we are seeing accentuated periurethral halo of lucency with periurethral hyperemia. Another case of prostatitis showing accentuated periurethral halo of lucency in homogeneous central zone and congested periprostatic venous plexus. Conclusion: three-dimensional transrectal ultrasonography had increased the accuracy, specificity, and sensitivity of ultrasonography in detection of prostate cancer and in evaluating extracapsular spread of tumor. Three-dimensional ultrasonography was more accurate than two-dimensional ultrasonography in estimating the volume of adenomas in cases with BBH. Three-dimensional ultrasonography and the power Doppler sonography are very valuable in evaluating cases with prostatitis. Thanks.